can't stop themselves. And what we're going to hear today is exactly why we need Prop 46. We need a deterrent to substance abuse in the medical profession, because if medical professionals don't know that they're going to get caught by abusing substance, and they have easy access to prescription drugs because they write their own prescriptions, then patients are going to continue to be in peril. And particularly in a state like California, where patients can't get access to justice because we have 38-year-old laws that deny them that access. Prop 46 deals with all these problems. And to talk about why we're here, why Prop 46 is on the ballot in November, is Bob Taft, who is the proponent of the initiative, a father who really has inspired us all to fight this fight. And I'm so glad to welcome Bob.
Thank you, Bob.
Yeah, good morning, and thank you for attending and coming. A little over 10 years ago, I lost my two children, my 10-year-old son, Troy, and 7-year-old daughter, Alana, to a hit-and-run driver who was abusing prescription narcotics. They were both killed, and when I learned that the driver that ran them over had obtained thousands of narcotics from a single HMO, a single hospital, where 6 doctors prescribed these medications to her without ever verifying an injury, without ever talking to each other, and without sharing a medical file. And this disturbed me because had they done that, my 2 children could be alive today. So I set out on a path of patient safety, of trying to do something about it. And the last years, I worked diligently with the Department of Justice to help build an electronic database known as CURES. It would allow doctors and pharmacists to instantly access a patient's narcotic history in real time, directly from their office, so they would know whether that patient is doctor shopping for narcotics, and would be a beneficial tool so that they can protect themselves, so they know their patient, no different than that doctor checking their medical file, their physical medical file. When they walk into the room to greet you, they're looking to understand what your needs are, and that's what this database does. But disturbingly, the CMA has fought this. They have fought the mandatory use by doctors to check this database. And so today, with Prop 46, we are bringing several initiatives together in one package, which is all about consumer and patient safety. Jamie touched upon the first element, which is mandatory random drug testing of doctors. This is necessary because when the citizens of California and, for the most part, our nation demand and want pilots to be drug tested. They want police to be drug tested. They want bus drivers. When these professions are high-risk professions that hold citizens' lives in their hand, people want to be protected, and random drug testing of doctors is necessary. It's not about the 90% or so of great doctors, of diligent doctors. It's those smaller percentage of bad apples that need to be identified and allowed to get into rehab before coming back to practice, so that when you go into a doctor or you're going to have an operation, you know that that doctor is sober 100%, just like when you get on an airplane. The second element is the CURES database, which I briefly touched on. The electronic database. This is so necessary in California. 49 states have databases. 16 states have electronic access to the databases now. And 3 states make it mandatory for doctors to check that database. Why should California be no different? We're the largest prescribing state of narcotics in the nation. Over 55 million prescriptions per year for narcotics are written in California. That's up from 3 million prescriptions in 2002. Everyone knows that this is an epidemic and something needs to be done about it. And the CURES database, by checking of doctors before they prescribe, is the most effective tool by any standard that can reduce doctor shopping, and save our state of California over $400 million a year in wasted resources such as police and fire department, emergency room visits. We can better use that money by identifying doctor shopping, reducing prescription drug numbers, and use that money somewhere like our school systems. It's appalling for me as a father to know that 12% of our middle school students are abusing prescription narcotics, and 25% of our high school seniors are abusing prescription narcotics. We can greatly reduce that through Prop 46. And finally, the third and last component is the micro-law. The micro-law is an egregious law that victimizes patients who have been harmed by medical negligence a second time. And I know that because when I wanted to bring the doctors who prescribe all these medications willy-nilly to the woman who ran over and killed my children and injured my wife, I was unable to because of this law that caps death and pain and suffering at $250,000. The life of a child in the state of California is worth at most $250,000. But it's difficult to get to court because you have to go through 2 to 3 years and spend $200,000 to get to court. So you're struggling just to get back what you're going to put into it in going through the legal system and the justice system, and that's not right. We have a very fair approach to this law, which is adjusted for inflation of the 39 years when this law was set in 1975 and bring it up to 1.1 million with a sliding scale of the more that goes to the patient, less goes to the attorney. Under Prop 46, if you get a settlement of over $600,000, the attorney only receives 15%. That's a very fair law. We're looking out for the consumer and the harmed patient. And we need this in order to protect people's accountability, to give them closure, and to protect victims so they have some fairness access to the court system. So with that in mind...
We'll just pause 1 second.
Yeah,
we're going to just take one pause while one camera gets set up. Give it about 2 seconds for the next portion. Right?
Yeah, okay.
Are we good? Good. Stand up. All right. Get a mic going, and we'll be going in a second. Sorry about that.
Okay. Yeah.
All right. We're going to just pause in 1 second for a mic to get set up. We close?
Very good.
All right.
I'll just put the mic up there.
Yeah.
Hey, Jamie. San Diego. It's okay.
Okay.
I'll put up on the cell phone.
Okay. Sorry about that. That is a recorder, so let me just put it here so we're not going to hurt anyone here. Some other mic here.
Yeah.
All right, we're good. Sorry about that. Thanks for the pause.
Yeah. Okay, so back on the proposition and the safety components, one of the things that's really important is the abuse of prescription narcotics in the country and how some states have approached this. Dr. Stephen Loyd, who has come out from his home state of Tennessee, And Tennessee has been one of the most proactive states in trying to curb prescription drug abuse. They have a huge problem. Per capita, it's one of the most egregious in the country. And Tennessee has enacted not only an electronic database, but just recently they have enacted mandatory use of that database, checking a patient prior to prescribing addictive narcotics. And that's what we're trying to accomplish in California because they've had so much success. For example, Tennessee has been able to reduce prescribing, doctor shopping, by 75%. And New York has had similar results. That's fantastic. So with that, I'd like to introduce Dr. Stephen Loyd, who came out from Tennessee and has his own personal story to tell you. And one of them is from the perspective of being a doctor and understanding narcotic abuse, because he has had his own lifelong struggles with addiction of prescription painkillers, and he understands what it's like and the safety that's needed with Prop 46 in California. Dr. Loyd?
Thanks, Bob. Good morning. As Bob said, I'm Stephen Loyd. I'm an internal medicine physician in Tennessee. Johnson City, Tennessee is my hometown. I'm an associate professor of medicine at East Tennessee State University in the Quillen College of Medicine. And 10 years ago, in August of 10 years ago, I was in rehab. I'd just come out of a detox unit in July, shaking and shivering from withdrawals caused by abuse of opiate narcotics, mainly oxycodone and Vicodin, as well as benzodiazepines, Valium, Xanax, and Klonopin. At my worst, I was taking about 100 pills a day, every day, and I was working in my job. Now, you'd think that if somebody was taking 100 pills of Vicodin and oxycodone, OxyContin, that you would know. But I can tell you that a good chance is that you wouldn't. You wouldn't know. 6 weeks before I went to rehab, I stood up at our medical students' graduation ceremony, and I was honored as one of the faculty members that had the most influence on their previous 4 years of education. Now, keep in mind, we have about 100 faculty members at our medical school. I was one of about 10 that was recognized that day, and I had used the entire time that those kids were in medical school. I had just been to the bathroom during the ceremony and used about 160 milligrams of OxyContin. You won't know. Here's the scariest thing about it. I thought I was a better doctor. I thought I was sharper, thought I didn't need sleep, thought I didn't need to eat, I could go longer, I could see more patients. My judgment was impaired. I thought it was better, and I wasn't better. I was worse. The only reason that I didn't hurt anybody was because of the incredible competency of the folks working around me. I had great folks working around me. My nurses, my fellow doctors were incredible. Would bring stuff back to me constantly, ask me to re-look at it. The one thing they didn't do was intervene on me. Why didn't they intervene on me? They couldn't. We're the only profession that I know of that are charged to police ourselves, yet we don't have the ability. I'll tell you one quick story, my low point, and I talked about this in several articles. My low point was a day in the ICU that I was rounding with the medical residents. If any of you know anything about medical education, or if you've ever been in a teaching hospital, you kind of round in a mass with the attending physician in the middle and the medical students and residents all around you. We always start the day off in the intensive care unit because that's where the sickest patients are. We got down to the ICU that morning, and we had a lady in there who was in for a drug overdose. And we were getting ready to put her on a helicopter to go to Vanderbilt. She needed a liver transplant. And I looked at the residents and I said, "What did she take?" And they told me, and I started to get nervous because I was taking the same types of medications. And I said, "How many did she take?" And they told me. And I literally, this is before electronic medical record 10 years ago, I couldn't put my pencil down to the paper to write my note because I was taking more on a daily basis than she took that night to overdose and be needed to fly 350 miles away to Vanderbilt for a liver transplant. I couldn't finish my note, yet I couldn't tell anybody because I'd lose my license, I'd lose my livelihood. I had plenty of friends around that would have listened, but there's no way I could tell anyone. And I dismissed rounds, and residents and students were all looking at me and wondering what was going on. and there was a bathroom just off of our ICU, and I walked into the bathroom. I looked at myself in the mirror, and I looked terrible. I weighed 173 pounds. My eyes were dark. I looked awful, and I just cried because I thought I was going to die, and I didn't think anybody was going to catch me. Luckily, a few months later, my dad actually caught me, and it was just a happenstance that my dad came out here with me. And I don't like to travel alone, so Dad did come with me. But my dad is the one who intervened on me. It wasn't any of my colleagues. My colleagues all knew something was wrong. They knew I wasn't the guy that I used to be. They knew I wasn't the Steve that they were in med school with. They knew I wasn't the Steve from early on in my residency. But nobody said anything. They didn't want to hurt my livelihood. They didn't want to damage my reputation. They didn't want to damage my practice. The truth of the matter is, I was going to die. And not only did I have the possibility of dying, I had the possibility of hurting a lot of people. I look back on it now. I talked to the Today Show about this, and it makes me shake to think about it. The damage I could have done to other people. And the reporter who interviewed me said, well, what if somebody sees this and realizes you could have damaged them? Then I need to be held accountable. How do you look at Bob Pack and say, well, we're not going to do anything? You lost 2 children, or Troy and Alana. How do you say we don't need to do anything? This is preventable. My state, the state of Tennessee, through the Prescription Safety Act of 2012, mandated that doctors query the prescription data bank. Well, I was a little bit off on these numbers, but not much. We dropped doctor shopping by 50% in the first year. We increased prosecutions for doctor shopping by 120%. How many lives did that save? How many Troys and Alanas are back at home with their dad instead of losing their life too soon? Last night in my hotel, I was looking at the list of opposition to Prop 46, and I'm appalled. I don't know how you take the focus off of people. That's what the focus of this is about. It's not about $250,000 caps or anything like that. The focus is about patients. It's about medical care provided by doctors who are not impaired. It's not about any of the other stuff. And that's where we need to keep our focus. And that's the reason I flew across the country, and that's the reason I'll continue to support Bob and his efforts, and that's the reason that California needs, the California Medical Board, the California Medical Association needs to put their money behind supporting what's trying to be done here and start to address the problem. Now, if you look at prescription drug abuse across the country, my area, my hometown, the area that I'm from, the Appalachians, we're going to be dark red, which is bad. Per capita, we're going to have the highest usages of prescription narcotics in the country. Okay, that's only because of our population. If you look at the sheer number of prescriptions, California is off the charts. Law enforcement here is really struggling because of the inaction of the California medical boards. It's time to do something about it, and that's why I'm here. I'm so glad that my dad's with him. It's an emotional thing for me to talk about, because if Dad hadn't have got me, I don't know that I'd be standing here in front of you. I am so honored to be here and to be a part of supporting this, and I thank you for inviting me.
Thank you, Dr. Loyd. I want to point out Dr. Loyd, in addition to practicing in Tennessee, is also the White House's Office of National Drug Control Policy 2014 Advocate for Action. If you go to the White House website, you'll see a video of Dr. Loyd talking, and the reason is, and I'm going to take a leap, I don't think there's another doctor in America who's openly and freely talked about his addiction.
Well, there may have been a few, but I appreciate that.
Currently we couldn't find one who would be open about it, because it is so dangerous and to their careers. And the courage that Dr. Loyd took in coming here and taking a stand is really important to us and to Bob and to all the patients in this coalition. If you go to Yes on 46, you will see the stories of patients who've lost limbs and haven't been able to get justice, families who've lost children and haven't been able to get justice, families who lost senior citizens and haven't been able to get justice. And the reason they haven't been able to get justice is the legal system is shut down to people who are not big wage earners, who don't have large medical bills. And so the third piece of this initiative really is, when you have a law that 38 years ago said the only people who have access to justice are people who have big wages and big medical bills, and otherwise you can get $250,000. Well, maybe in 1976 that kept some people in the legal system. In 2014, it costs over $100,000 to bring a case, literally in costs. That's not attorney's fees. That's deposing doctors. So if young men and women who are often those who are addicted to drugs are killed by overdoses, they don't have access to justice. And if doctors who are performing in the state, and there's a list in this packet now of doctors performing who've had multiple DUIs, who've had multiple dozens of lawsuits, who've had really significant problems reported by the state of walking out on patients and literally leave them in a vegetative state. This is happening now in the state. It's because the medical board hasn't done its job, they haven't been detected by drug testing, and the legal system can't get rid of them because it's archaic. And so that's what Prop 46 is all about, bringing together these patient safety elements. The statistic we gave you at the beginning is in a press release on the yeson46.com site and consumerwatchdog.org site, and I'm going to open it up to questions from anyone who has questions to anyone who's talked. And we're going to, I think, let's see if there's any questions in the room, and then we'll go to the people on the line and see if we can do it in an orderly way. Does anybody here want to ask a question?
The stat that you mentioned in the beginning, the 500,000 medical professionals, what kind of the breakdown of medical professionals?
Good question. Carmen, do you have the breakdown that we can share?
It does not. Actually, there's a link in the press release to the report with a citation to the page, and it shows you exactly what the breakdown of medical professionals is. It goes everything from doctors, nurses, technicians.
So the question from the room was on the statistic that 511,000 medical professionals reported substance abuse, which is almost 7% of the profession. How is that broken down by doctors versus EMTs versus others in the profession? And there is a link to the study. We know about physician drug abuse, specifically some other stats that come from the Medical Board of California, and maybe Dr. Loyd could talk a little to this. California Medical Board has estimated that at any given time, 1% to 2% of physicians, who are the only profession right now covered by the initiative, are abusing substances. That's based on an extrapolation of their treatment of doctors in a clinical health program that was discontinued because it turned out it was a revolving door for addicts, and the legislature discontinued. But their experience is doctors, 1% to 2% of the population. Over the course of a lifetime, however, there are estimates reported by the board, and they're not originated by the board, but they cite medical experts, the California Medical Board, saying that 18%, or roughly 1 in 5 physicians during their lifetime, have a substance abuse problem. I'd ask Dr. Loyd to talk to if that's consistent with those.
Those numbers are consistent. I've been doing talks on substance abuse now for about 10 years, and the generally accepted numbers are about a 2% point prevalence and anywhere from a 10 to 18% lifetime prevalence. So those numbers are consistent.
Among physicians?
Among physicians specifically, yes.
And that is higher than the general population, particularly on prescription drugs, as you might expect, because doctors have that prescription ad. By the way, Dr. Loyd, do you want to say anything about what the medical profession is really seizing on is the mandatory drug testing? Can you talk a little bit about what you think that is in terms of how effective that could be in terms of deterrence?
Right. The mandatory drug testing, and I talked about this when I was fortunate enough to go to the White House, and it's actually on the White House's website, is I do believe in mandatory drug testing. You know, doctors are trusted to police themselves, but I told you that to this point we've been incapable of doing so. And mandatory drug testing is really our only alternative. So if we're incapable, then we're going to have another alternative, and urine drug screening or saliva drug screening is going to be the answer there. I can tell you this, that I was under a 5-year contract whenever I got help, and I submitted to random urine drug screening for those 5 years, and it was on a decreasing level as time went on. At the end of the 5 years, I signed a lifetime contract. So it's about accountability in addictive disease. And so I called this morning, as a matter of fact, before I came over here to see if I needed to be randomly urine drug screened. So it's not a punitive thing. It's about being held accountable to make sure that I'm doing the things I need to do to take care of my addictive disease, much like a diabetic would to take care of their blood sugars if they're on insulin. So I think that drug screening gives us the best objective tool that we can have to make sure that our doctors are not abusing narcotics, because it is a very difficult thing to come out and say. I've done this for so long now, but I can tell you at the end of the day today, I will be exhausted, because it is emotionally exhausting to bare your soul in front of people and tell them things that you've done, because we look at addiction as a moral failure instead of a disease.
I just want to note that Dr. Loyd's father, who's here today with him for people on the phone, is a Teamster. And Teamsters are tested for drug and alcohol. And the model for this initiative, which the Teamsters support, Prop 46, is the federal transportation rules applying to pilots and truck drivers. And it gives a lot, actually, of once someone has a positive result, they have an opportunity to have it verified, to explain it. But ultimately, at least they've been detected. And, of course, get treatment, because it's up to the medical board to deal with them. But what we do is make sure that there's a verifiable result that and it's showing substance abuse on the job, that the doctor has an interim suspension of their license until we figure out how to treat their addiction, or if they can't treat their addiction, they have to lose their license. But right now, what is remarkable is the Medical Board of California cannot require a doctor to take a drug test in the state of California. They can't compel it. The only way they can compel it is by prosecuting a case against that doctor, which can take 5 years, 8 years, literally, routinely, and then as a condition of settling and not losing their license, they may have to make that agreement. But in the meantime, there's a lot of damage to patients that can be done. And so that's why this initiative is so important. Is anyone else in the room have a question before I go to the phone lines? Or another question, a follow-up question? Go ahead, sorry, go ahead.
Two-part question. Dr. Loyd, are you still practicing medicine? And then my follow-up question is, if a doctor, supposing Prop 46 passes and the doctor does test positive in a drug test, either through Prop 46 or current law in California, what are the consequences?
Let me just, the two-part question. Are you currently practicing medicine? And two, what happens as the consequences of a positive test under 46? And I'm happy to help on that second question.
I'll let Jamie handle the second part of that question. And the first part is, am I still practicing medicine? Yesterday, before I got on the plane to come to the Bay Area, I found out that I got the job as chief of medicine at my hospital. So, yes, I still practice medicine. And matter of fact, I can't even begin to tell you the trajectory my career has been on for the past 10 years. And thank you for asking that question, by the way, because we don't talk enough about this. And this is the other side of treatment. It's what Bob talked about, is that we have all of these different groups of folks out here opposing Prop 46 and identifying doctors who are drug abusing. How about taking this slant on it? Let's identify them and help them fix their lives and put them on a career trajectory that they never imagined for themselves before they go down the toilet and take a bunch of people with them, including their own families, because that's what I was doing. And I stayed in my job thanks to the state of Tennessee's physician health programs and the effectiveness of the medical boards in my state, which you all don't have the luxury of here in California. And I missed 3 months of work while I was in treatment. When I came back, I was under monitoring and supervision. I still have a work site monitor. All of that is voluntary, but to be honest with you, I'd never had a successful 5-year stint like that in my life, and so I signed a voluntary lifetime contract at that point because I didn't want to change things. But I didn't have to, and that's not mandatory, but I still have a work site monitor. I think we need to take a little bit different approach at it. A lot of your drug-using docs out there are waiting for somebody to reach out and get them. I was. When Dad intervened on me, I felt like a guy that was out in the middle of the ocean and somebody came by in a boat and slung him a life raft. And there's a good percentage of folks out there like that right now, and yet we have a lot of people opposing this on grounds that I can't understand. So not only am I practicing To be honest with you, it's hard to wipe the smile off my face.
In terms of what the initiative does, it basically directs, and we can walk you through, anybody who wants to, the provisions, but it basically directs the medical board to come up with regulations implementing a random drug testing based on federal transportation guidelines for truckers and pilots who are randomly drug tested. And the only direction it gives is really it has to be consistent with those federal regulations now apply to pilots and truck drivers, transportation workers, and it also has to be consistent with the California Constitution and the U.S. Constitution and the provisions of Prop 46, which are protecting patients from substance abuse by treating physicians and substance abuse generally, by overprescribing. And so what that would mean in pragmatically, because we have definitions in the initiative, is you get a random test for doctors who have hospital privileges, and the board could skew it towards people who do more surgeries in a hospital. And if someone tests positive, they have an opportunity to then contest it because there'll be a second sample. They also have an opportunity to get it to be heard and to create an explanation for why they had that in their system. It could be that they had a prescription. It could be that it was not a verifiable positive because it didn't relate to any substances that could be proved they used at work. And then at that moment, if they can't make the case that it's not a verifiable positive, then that verifiable positive, after having the opportunity to go through a medical advocate or a medical monitor and make that case, if they lose that case, then that gets transmitted to the board, and the board says it has to take action. The only action it has to take is on an interim basis to suspend their license. After that, the action can be rehabbed. The action will be case dependent. But if we have a verifiable positive after the doctor has every explanation to explain it, to contest it, to appeal it, if they can't do any of that, let's say they've got opioids in their system and the concentration is clear, then you have an interim suspension of their license until there's an action plan determined by the medical board. Let me see if I can. Let me get off mode. If anybody on the call has a question, and we're going to have to speak one at a time because we're not high tech here, you can just raise their voice now. Anybody on the line still with us have a question? All right. If not, I'll go back to the room. Anybody else have a question in the room?
Just your intro, your first and last name, spell it for me, please.
Okay. Sure. I'm Jamie Court, Jamie Court with Consumer Watchdog. You want to spell your name and just talk about your...
Stephen Loyd, Stephen, Loyd, Loyd.
And Bob, do you want to go to... Oh, Bob, okay. All right, so we're good. Anyone else have any questions? If not, I just want to, resource-wise, YesOn46.com will have our press release today. It's also at consumerwatchdog.org. If you want to get a hold of Dr. Loyd to talk later, you can call Lisa Cohen at 310-395-2544, 310-395-2544. You can also call Carmen Balber at 310-403-0284 or myself at 310-874-9989. So any follow-up we can't do on the phone, Lisa Cohen is the primary point person at 310-395-2544. Thanks for coming, and if you want to get on our list and haven't been on the list, you can also email us, and that's all at yesOn46.org. Thank you.